Alexandria University, and she will present a talk about multiparametric MRI roadmap to renal mass characterization.
Good morning, everyone. It's my pleasure to be here today. We're going to go through a quick review on the multiparametric MRI of solid renal masses. So, first, we have 3 questions to answer. Why do we do a multiparametric MRI? How do we do it? And how to interpret what we see. In interpretation, we'll talk quickly about 2 things, the clear cell likelihood score and the newly evolving chi-rads. So, why do we do an multiparametric MRI? The solid renal masses, or what we call small renal masses, are becoming a very common incidental finding in cross-sectional imaging. A small mass is defined as small if it's 4 centimeters or less, and it is defined as solid if it contains more than 25% of enhancing component. The multiparametric MRI, the basic multiparametric MRI of the kidneys contains a T1 imaging sequences, T2 coronal and axial, T2 fat sat, chemical shift imaging, the diffusion weighted imaging, and the dynamic contrast enhanced imaging. So the clear cell likelihood score is actually a way of standardization of what we are interpreting. It gives a score from 1 to 5, 1 being the very unlikely to be a clear cell, and 5 being very likely to be clear cell. Why do we insist on clear cell? Clear cell is the most common and the most aggressive in the same time. So our aim is to say, is it a clear cell? Does it need an aggressive treatment? Or no, it is not a clear cell. We'll look into more indolent tumors. So we count on 6 features, 3 measures and 3 ancillary features. The major features is the T2 signal. Is it hyper, iso, or hypointense? It's a visual assessment. The next feature is the corticomedullary phase enhancement. It can be visually assessed. If it's not, we can calculate it, but we usually resort to the visual assessment. Then we look for the presence of microscopic fat within the lesion on chemical shift imaging. Now, the 3 ancillary features are the segmental enhancement inversion, which is the inversion of enhancement between the corticomedullary and delayed phases, and the arterial to delay enhancement, or the washout curve, and the diffusion weighted images. So now we have the clear cell likelihood score. It's quite a big algorithm. So we are going to try to go through some cases, putting them on the algorithm. So this is a case from our work here at the university. This is a T2 hyperintense lesion. Pardon. So we can see the lesion is a T2 hyperintense lesion. So we look for the next stage, it's the corticomedullary phase enhancement. The lesion is intensely enhancing. So we look for microscopic fat. So the lesion do contain microscopic fat. Quickly go to, okay, this is a hyperintense lesion with intense enhancement, microscopic fat. It takes a score of 5. It's a clear cell RCC. It's a pathologically proven clear cell RCC. So during our work here in the university, it was before the clear cell likelihood score. So we tried to do another algorithm to detect the cases. So here we started with the diffusion, and we went on through to the T2 signal, the enhancement pattern, and the chemical shift imaging. We just added the diffusion at the start. The clear cell is actually a lower diffusion. The EDC is higher in clear cells than the other lesions. So this was 1.4. The T2 signal was hyper intense. It was a clear cell RCC showing drop of signal, and if we go to the curve of the lesion, it is showing a washout enhancement. So this is another lesion. This time it's an iso-intense lesion. We go for the enhancement. It's moderately enhancing. We look for microscopic fat, no microscopic fat. So what's next? We look for segmental enhancement inversion. Yes, there is a central scar. We can see that in the scar in the delayed images. It's becoming enhancing, and the part that was intensely enhancement in the start is no longer enhancing. So we actually have a score of 2, and this case was a proven oncocytoma. The oncocytoma usually have a lower ADC. It's about 1.1. It's lower than the clear cell RCC. So we go through it's more than 1.1 or equal. It's an iso-intense. It contains no fat. So it's an oncocytoma. And if we go for the curve, it's more of a plateau with no washout curve. So this is another lesion. This time it's a hypointense lesion. So we look for the enhancement. The lesion is mildly enhancing. It contains no fat, so it's a score of 1 actually, which is the farthest from clear cell. It's a papillary RCC. The papillary RCC usually are restricted, and the EDC is 0.9. So it's a hypointense, it's mildly enhancing, it shows no washout, and it contains no fat. It's a papillary RCC. Now, not every case is a clear, well-defined, homogeneous lesion. Sometimes we have what we call blooming from hemorrhage inside, from hemorrhage inside the tumor. So still it's a hypointense. We look for the solid enhancing component. We don't care about the blooming. So it's a solid lesion. It's a hypointense lesion. It showed moderate enhancement. Still it notes the presence of microscopic fat. So this will case of take a score of 3. Actually, it was a lipid-poor angiomyolipoma. So this is our case. It had an EDC of 0.8. It's even more restricted. We go on. It's a restricted case, less than 1.1. It's a hypointense. It showed mild enhancement with a washout. Usually the angiomyolipoma are hypervascular, even if it's lipid-poor. And we go on for an angiomyolipoma. Now, this is a case from the literature. This is an isointense case. We look for the enhancement. It's moderately enhancing. There is no inversion of enhancement in this case, so we go for so this is an isointense with moderate enhancement. The lesion contained no microscopic fat. There were no enhancement inversion. The case was a chromophobe RCC. So we solved the problem, right? No, we did. Actually, the algorithm is it's standardized, it helps in the diagnosis, but it's not enough. Still, it's not enough. We have a problem, what we call the cystic RCC. All what we are talking about are the solid lesion, but we actually need to combine the solid and the cystic lesions. So we need a single, with cystic lesion, we have the Bosnia classification. Now the solid lesion, we have the clear cell likelihood score, but we need something to combine both. So now we are pursuing to have a chi-rads combining both the cystic and the solid lesions into one algorithm, looking for the aggressiveness of the tumor, with 1 being the least aggressive and 5 being the most aggressive. So the goal of the chi-rads is actually to combine both the cystic and the solid lesion into one rubric. So what we have now is we have a renal mass. We exclude the infection. If it's cystic with less than 25% enhancement, we go for the Bosnia classification. If it's solid, contain macroscopic fat, then it's a classic angiomyolipoma. And if it's not what we call indeterminate, we go for the clear cell likelihood score. And based on it, on the Bosniak and the clear cell likelihood, we take the biopsy or go for treatment decisions. We try to go a little deeper, so we said, okay, it's cystic, it's solid, and we see the RCC subtype, not just it's a solid tumor. No, we go for subtyping. Is it a papillary? Is it a clear cell? Is it a chromophobe? Is it other? And we take the biopsy and see the treatment decision. Now, the chi-rads, well, it doesn't divide into cystic and solid. We go for, it's a renal mass. We exclude if it's an inflammatory or a vascular mass, and we assess the probability of cancer. Is it benign, like a simple cyst, a classic angiomyolipoma with macroscopic fat, or is it possible cancer? We assess the likelihood of cancer based on the aggressiveness of the lesion. Does it grow? Does it have hypervascularity? Is it diffusion restriction? And we assign. And based on what we assign, we actually go for biopsy or surveillance. I'm not sure here in Alexandria, we don't go much for surveillance, but a lot of cases, even if it's papillary, they go for surveillance and say it's okay, it's an indolent, malignant and indolent tumor that doesn't usually metastasize. If the patient is old, we can go on for follow-up and biopsy, or we treat if it's an aggressive, malignant and aggressive tumor, and we go on for nephrectomy, either total or partial. Thank you for your attention.